Happy to have you. I'm Stephanie Bauer. I'm a nurse coordinator at Ascension Providence Hospital's Community Health and Education Department. I'm really glad you could join us tonight. We are really pleased to have Dr. Lacoste with us. He's going to be talking about PTSD, and this is part of our Your Mind Matters series that we have at Ascension. So we're really happy to have him. I wanted to let you know that if you have questions, you can use the Zoom chat feature. Marianne will set that up, and it should be at the bottom of your screen, but you can definitely type in any questions. I will collect those and read those to Dr. Lacoste at the end of his presentation. Just so you know, with this Your Mind Matters series, we do have another presentation coming up on November 10th, so look for that. It's Managing Anxiety and Depression, and that's hosted by the Rochester Hills Public Library. But I'd like to introduce tonight's presenter, Dr. Robert Lacoste. He graduated from medical school at Wayne State University and did his residency at Sinai Hospital in psychiatry. He's been board certified since 1993 and has been in practice for more than 30 years. So has tons of knowledge and practice. He actually had a private practice for 12 years in Birmingham, Michigan, and has been at Ascension Providence Rochester Hospital since 2009 as our medical director of the Behavioral Health Unit and our chief of psychiatry. Please welcome Dr. Lacoste.
Thank you, Stephanie. Good evening, everyone. So I entitled this presentation, The ABCs of PTSD. We're going to look at the basic facts. So relax, enjoy the ride. I'm going to make this as entertaining as I can. So we're going to start with a definition of psychological trauma. So in general, trauma can be defined as a psychological or emotional response to an event or an experience that is deeply distressing or disturbing. So that's the key here. Anything deeply distressing or disturbing can be potentially traumatic from a psychological standpoint. So if we apply this definition loosely, that could refer to anything upsetting, anything from being involved in an accident, being diagnosed with a disease, losing a loved one, or even going through a divorce. However, most psychological traumas do not lead to PTSD. Those that do tend to be more severe, sudden, and typically outside of the range of normal experiences. So in other words, not all traumas are created equal. Case in point, obviously, 9/11. It certainly would fit the definition. It was sudden, severe, and outside of normal experiences. We'll be returning to 9/11 several times during this presentation because it is a very good example of a traumatic event that can lead to PTSD. In addition, different people have different thresholds to develop PTSD. In other words, being exposed to something that's severe is usually not enough to explain why some people do develop PTSD and some don't. We have to take into account personal vulnerabilities that each of us has, some more than others. And we'll be taking a look at what these predisposing factors are that would make us statistically more likely to develop PTSD. So this is what a personal vulnerability might look like, something like a weak link. So in summary, there are two main things have to happen in order to develop PTSD. One, some of it depends on how vulnerable you are. For example, if you've been traumatized before, it makes it easier to develop PTSD once you're traumatized again. And then we need to have, of course, a traumatic event. So before we proceed and start looking at these predisposing factors, I thought we would take a small detour and have a brief history of PTSD, starting in World War I and World War II. So in World War I, it was called shell shock. It became combat fatigue in World War II. And without any doubt, this was attributed to traumatic events. However, back then, the idea was that once that individual is taken out of the environment, the symptoms should go away. And if the symptoms did not go away, this was then presumed to be due to the individual predispositions. So it was in essence blamed on the individual. There was something wrong with the individual that made it that they couldn't recover. And then they were given a different diagnosis. So they may have been given a stress reaction while they were in the field. Once they came home and continued to have symptoms, then it became a neurotic disorder, for example. So this is how things were viewed back then. However, the Vietnam War changed everything in terms of traumatic diagnoses. And this is a picture from the Vietnam War. A highly politicized anti-war atmosphere pervaded, of course, much of the country, including many returning veterans who had turned against the war. There's a group called Vietnam Veterans Against the War that was founded in '67 to oppose US policy and participation in the war. And of course, these are pictures from the late '60s and early '70s. And here's a demonstration by the Vietnam Veterans Against the War. That group, along with anti-war psychiatrists, Doctors Lifton and Chatan, became convinced that large numbers of veterans were experiencing what they called back then a post-Vietnam syndrome, with guilt, flashbacks, rage. They felt numb, alienated, and scapegoated. Now, it just so happens that right around that time in 1974, the American Psychiatric Association was revising its diagnostic manual, because up until then, there was no traumatic diagnosis for people who remained symptomatic once they were out of the environment. So the psychiatrists, Lifton and Chatan, took advantage of this revision process to try to remedy the absence of a diagnostic category that would cover those enduring psychological symptoms of traumatic conditions. It was an opportunity. This led to the birth of PTSD. In 1980, the American Psychiatric Association added post-traumatic stress disorder to their diagnostic manual. So this manual is something, it's like the Bible of psychiatric disorders, if you want. It's been termed that. Everything that is deemed a psychiatric disorder is listed along with some criteria that have to be met in order for these diagnoses to be given. They also come with what you call a diagnostic code, which the psychiatrist then has to use when they send a bill to the insurance company. So with the birth of PTSD in 1980, this was the first time that the cause of this disorder was attributed to the traumatic event rather than to some weakness of the individual. And this is actually what DSM-3 looked like in 1980. And I don't know who picked that color, but it certainly is a bit jarring. So let's go back to our main presentation now that we've taken a brief overlook at how PTSD came to be. So you may be wondering, since I made reference to 1980, that was 40 years ago. So what is nowadays definition of PTSD? Because it's 40 years later, and the manual has been revised several times since. The last revision was in 2015 with what they call DSM-5. So if we look at how PTSD is defined and what needs to happen for someone to receive a diagnosis of PTSD, these are the criteria. So you have to be exposed to one or more events that involved death or threatened death, actual or threatened serious injury, or threatened sexual violation. So either this is happening directly to you, or you're witnessing this happening to someone else. You're there and you're seeing it. Or you may be learning that a very close friend or relative of yours it's happened to them. And finally, if you're a first responder, for example, and you are exposed repeatedly to distressing details of those events, that's the last criterion here. You could potentially develop PTSD. In addition, you would have to have certain symptoms, and we'll go over what these symptoms are like. So you would have to experience specific symptoms. You would have to have these symptoms for longer than a month. And these symptoms would have to be very distressing or incapacitating. Now, just so you know, a month is an arbitrary figure here. It's an arbitrary number. This is a committee that came up with this definition and these criteria. So they could have chosen to make it less or a longer period of time, which then, of course, would change the frequency of these diagnoses. But this is their best guess. These were experts in the field that were trying to come up with this definition. So now that we've defined the current definition, let's take a look at just how prevalent is it. And prevalence refers to the total number of individuals in a population who have a disease at a specific period of time, and usually it's expressed as a percentage. So the numbers for PTSD are the following. Lifetime prevalence means what percentage of Americans will develop PTSD in their lifetime. And that number is about 7%. And you can see that for men, it's about half the number it is for women, and actually less than half. Now, past year prevalence means the percentage of Americans that had a diagnosis of PTSD in the last year, 3.5%. So we're looking at a, minority of individuals. These are relatively low percentages. Now, these are the predisposing factors that we're going to be taking a look at one at a time. These are the things that statistically may make it more likely that you may develop PTSD than not. They're not guarantees, but the more of these predisposing factors you have, it lowers your threshold and makes it a little bit easier to develop PTSD the next time you're exposed to a traumatic event. So the first thing is, of course, female gender. I just mentioned that the percentage is much higher in women. Women are twice as likely than men to develop PTSD, even though they're exposed to a third less traumatic events than men. Of course, sexual assault is the most frequent type of event reported by women with PTSD, with one study showing 2/3 of women with PTSD having been raped or sexually assaulted. So as to why is there such a discrepancy or difference between the two gender? Well, societal attitudes may have something to do with it, especially when you're talking about sexual assault, since this oftentimes will come with judgment on the part of others and guilt on the part of the victim. Gender roles where women are usually expected to be more emotional and to express their emotions more openly. And even something like income inequality, since women are often paid less for the same amount of work than men. These all could be possible reasons why being a woman puts you in a higher risk category. Another predisposing factor is the younger age. Now, if you think about it, that makes sense. If you're a child or an adolescent, you're not a finished product. And as a result, your ability to cope is going to be much less sophisticated than it might be if you were fully grown. So some of the numbers is more than 2/3 of children in the US will have at least one traumatic event by the age of 16. And of those who experience trauma, 16% will go on to develop PTSD. So 16%, as you can see, is higher than the numbers we were just looking at. In addition, 30 to 40% of children who experience physical or sexual abuse also go on to develop PTSD. Now, that's an even higher number, which is probably accounted for by the fact that usually physical and sexual abuse tend to be ongoing for a significant period of time. And that would make it more likely to cause PTSD. As far as the good news, well, for those of us that are 60 and older, the prevalence of exposure to trauma is lower. So we're less likely to be exposed to trauma if we're 60 and older. And we're also less likely to develop PTSD. I'd like to think that that's because we have some wisdom and we have some resilience. And if we've made it to 60, maybe that is enabled us to cope better. At any rate, this is where age comes from. Now, lower education is also a predisposing factor. That may not sound particularly intuitive here, but level of education indirectly influences such things as economic resources. So if you don't have the means to pay for your copays, it's going to be difficult to seek treatment. Social status will be determined also by, to some degree, your level of education. So if you live in an urban setting, you may be more likely to be exposed to traumatic events. How many social networks you have? Well, if you're living in an urban setting, you're probably not a member of the tennis club. and you may have limited social networks that could also act as support. And finally, lower education has been associated also with health behavior, meaning the higher your education, the more likely that you may pay attention to your health, be aware of your diet, and even seek treatment when you start noticing some symptoms, or see doctors on a regular basis. Now, socioeconomic status is another factor. Now, this one is because if you're living in an urban setting, low-income housing, the idea is that you're more likely to be exposed to trauma in a situation like that. And that is what makes you more likely to potentially develop PTSD. Lack of social support. If you know that you have friends, family members, and others that you can reach out to, that's great. And that's what perceived social support is all about. The less social support you have, the more likely you could develop PTSD following a traumatic event. So if you were recently widowed, they would put you statistically in a higher category. Now, I mentioned that earlier, previous trauma would also be a factor. History of any previous exposure to traumatic events was associated with a greater risk of PTSD from the following trauma. And as you might expect, it's cumulative. So multiple previous events have a stronger effect than a single previous event. No surprises here, psychiatric history. If you have mental health issues or substance abuse issues, that could make coping more difficult. In addition, if these problems have caused you to lose your job, that could affect your socioeconomic status. And as a result of repeated episodes, you may have lost some of the social support over the years. Other ways that these mental health issues might predispose you to develop PTSD. Finally, the last one is genetics. When they've done studies with identical twins and compared them with fraternal twins that were exposed to the same trauma, more of the identical twins develop PTSD than the fraternal twins, meaning that there is a small genetic component. They estimated the heritability to be 30 to 40%. What that means is that something that is 100% genetic would have a heritability of 100%. Something that is absolutely nothing genetic about it would be 0. So 30 to 40 tells us that there's some genetic component, but it's not the most important. So now we move from the individual to aspects of the traumatic event, because certain events will be more likely to cause or lead to PTSD than others. So let's take a look at that. And of course, this is here a reference to 9/11 again. As you would expect, the greater the exposure, meaning the more intense and or prolonged, the greater the risk of developing PTSD. So going back to 9/11, if you're in the towers and you're one of the survivors of the towers after the first impact, that's about as intense as it could have been. Becoming physically injured is another risk factor. If you're injured as a result of a traumatic event, it makes it more traumatic. And it is a risk factor. And finally, one that I wasn't aware of until I started working on this presentation, if it's something intentional, like 9/11, versus something accidental, where something just happens because it's bad luck, and it's not because somebody else is doing something to you, anything intentional seems to be more upsetting, and therefore can lead to a greater response and potentially can lead to PTSD. So, for example, 9/11, of course, they did some surveys after 9/11, and when they surveyed the New York City general population, they found that 1 month after the attack, 7.5% of people met criteria for PTSD. However, 6 months later, only 0.6% did. I remember back at that time, experts were predicting massive numbers of people who would develop PTSD, even outside of New York City, because we all saw it on TV and we all saw it over and over again. However, that hasn't happened to turn out to be true. So 1 month later, a significant number. But over time, if you were living in New York but were not more directly involved in this, it went down to 0.6. Relief workers that spent 1 week on the scene within the first 2 months after the attack, 4.6% met criteria for PTSD versus 6.4, and these are those first responders that were also exposed to ground zero. So some significant numbers. However, 6 to 8 months later, 0% met criteria for PTSD. Now, if we compare that, so there's some degree of exposure here, but it's relatively mild compared to being a survivor in the towers between the first plane impact and the collapse. Of those folks, still nowadays, 14 years later, so that would have been in 2015, 13% of survivors meet criteria for PTSD still in 2015. And of course, these were the ones that were most exposed based on what we've just been talking about. So time to move on to symptoms. So if you have PTSD, or if you're wondering if you have it, what kind of symptoms are you displaying or anticipating you might display? There are 4 types of symptoms. They're grouped into these 4 categories, and we'll take a look at each one of them. So one is re-experiencing. Another one is called avoidance. There's hyperarousal, and finally, negative thoughts. Re-experiencing. You find yourself having intrusive thoughts and memories. You're not trying to remember what happened, but your mind just seems to bring it up. Either something triggers you, you see someone that resembles the active shooter at Walmart when you were there, and it brings that issue right up. So you're not trying to think about it, but it intrudes upon your thinking. Nightmares and dreams, kind of similar, except it's happening at night. And flashbacks. Flashbacks are intense emotional experiences where for a brief moment, you feel as if you're back experiencing the original trauma. And a perfect example of that is when you go to fireworks and you've been to Vietnam or wherever else. And when the fireworks first start, or maybe they were louder because they were closer, somehow you find yourself reacting as if you were back in combat for a few seconds. That would be a flashback. Avoidance. Well, you have these intrusive thoughts and memories. You are trying not to think about what happened, so you try not to think about it. You avoid thoughts and feelings about the event. You also find yourself avoiding places or people that are triggering you about the event. Because basically you're trying not to have any of these recollections or memories, or because they're upsetting. So avoidance of places and people and thoughts and feelings. Hyperarousal. You're on edge. You're hypervigilant. You're finding it difficult to sleep, falling asleep, staying asleep. You're irritable and you're easily startled. It kind of looks like this. Waiting for the other shoe to drop. And finally, negative thoughts. If you've been traumatized, it's usually difficult to have a more positive view of life. You probably feel like what happened may not have been fair. You may have negative thoughts about yourself, other people, especially if other people did something to you. You were robbed at gunpoint, or you were involved in an active shooter scenario at Walmart. You find yourself experiencing negative emotions more frequently: fear, anger, guilt, shame. You lose interest in some of the things that were more positive activities you were doing, playing racquetball, for example. You find yourself becoming more isolated, avoiding things, and it feels like it's difficult to feel positive emotions. So everything feels kind of dark. So you may be wondering, so what causes these symptoms? So What happens to the brain when the brain goes through a traumatic event? So this is what we're going to be talking about. And in order to do that, we're going to have a little crash course in neurobiology. I called it Neurobiology 101. So this is a brief video that's going to show you a model for the brain, and then we're going to build on that afterwards. So you'll come to understand how these symptoms come about, and also what needs to happen in order to tame those symptoms or to get better.
It started with a simple but effective idea, a way to visualize our rising emotions and help restore our calm, keeping our cool when flipping our lids. It's a hand model of the brain, the brainchild of Dr. Daniel Siegel, and here's how it works. Put your thumb in the middle of your palm and curl your fingers over the top. Now you have a model of the brain. Lift your fingers up and raise your thumb. That's the inner brainstem represented by your palm and wrist. The brainstem controls basic body functions like breathing, heart rate, and blood pressure. Put your thumb back down. That's the approximate location of the limbic area, most notably the amygdala, which helps to regulate emotions and our fight, flight, freeze response. Now, curl your fingers back over the top, and your prefrontal cortex, which allows us to think critically, predict consequences, control impulses, and do other executive functions, is in place. The frontmost part of the brain helps us rationally manage the amygdala and brainstem areas. But when our emotions start to rise, maybe someone's pushed your last button, or you perceive a threat or danger, our amygdala overrides the prefrontal area, and we can flip our lids, losing our cool, and acting in ways that can be scary to others. By visualizing our lid flipping and noticing when our emotions are rising, we can take a break or a deep breath and work to calm ourselves, giving our brainstem a chance to regulate our body and allowing us to actually change what the brain does and return to the clearer thinking of the prefrontal cortex. That's the power of using the hand model for ourselves and as a learning tool for our children.
So let's review our cast of characters. Three main entities: the amygdala, that's the alert system of the brain; the brainstem, which controls breathing, blood pressure, and all that; and then the prefrontal cortex, our more rational mind, with the amygdala and the limbic area, the emotional part of the brain. So let's talk about the amygdala a little bit more. First of all, there are two of them. There's those two little yellow spots there on each side of the brain. It is the alarm system of the brain. It receives input from all sensory modalities. So if you hear something, a noise at home in the dark, you're going to pay attention to it. If you see something in the shadow and you think it looks like a snake, but it's really a dead branch, you're going to first react like it's a snake or dangerous. So it can be activated without conscious awareness. And what that means is if you show someone a picture of an individual of another race, for example, for only 1/10 of a second, which is too fast to be consciously aware, the amygdala activates, because the amygdala recognizes that person to be different from you. So once the alarm sounds, and it goes something like this, then it gives rise to the fight or flight response. And this is to get you ready to run or fight. So the amygdala reacts to the threat. It then activates the hypothalamus. So there's a release of adrenaline. And other things are being also released into the bloodstream, like cortisol. And this leads to all these things on the left side here. Your pupils dilate, which means you can see better. Your mouth is dry and your digestion is slowed because you don't need to send blood to these organs. Blood has to go to the muscles and the heart. Your breathing becomes faster, your heart is pounding, and your palms are sweating. Now, the fight or flight response interferes with the frontal cortex. So when we flip our lid, it's because these hormones make it very difficult for the frontal cortex to control what we're paying attention to, make sense of what's happening, and after the fact, even recall our experience in an orderly manner. So you may wonder, why is that? I mean, why do these hormones interfere with the prefrontal cortex? Well, it's a very simple reason, because it's about survival. And evolution has favored those who didn't spend too much time thinking about what was going on and what to do next in life-threatening situations. You have to act. You don't have time to figure it out. You do that later. And then we move on to the third character, the frontal cortex, which is the area in green that you see here. This is the most recently evolved part of our brain. And it helps regulate emotions through thought. And this is in a way how cognitive behavioral therapy is about. It's about using your prefrontal cortex to help you tame the emotional limbic area. So if we go back to our example, show someone a picture of an individual of another race for only 1/10 of a second, the amygdala activates. But if you show the picture for a longer time, the amygdala will activate, but the frontal cortex will activate also, and then it will inhibit the amygdala, because then you have realized that there is no danger. So the prefrontal cortex, for those of you who are familiar with the original Star Trek, would be like Spock. And the prefrontal cortex mediates fear extinction. In other words, you don't forget something that you've learned to fear. You have to kind of learn that it's not dangerous anymore, or that it's not going to happen. And in order to do that, you have to use your prefrontal cortex. So you may be wondering, now that we've finished our Neurobiology 101 course, how does PTSD develop? Well, in normal situations, our brain will store events in both what they call explicit and implicit memory systems. So it will be stored in the cortex and the limbic system. But when we experience something that brings on intense fear, the amygdala hijacks the cortex and prevents the brain's ability to store the event and the contextual details. As a result, your amygdala will remember it, but you will not have a lot of the details and contextual information. So what that means is, let's say we go back to our example of an active shooter at Walmart, and it just happens that you were in the frozen food section when you heard the first gunshot. So eventually, you go back to Walmart at some point, and for reasons that are unclear to you, as you enter the frozen food section, you start getting anxious. But you have no idea why you're getting anxious, because you don't remember that that's where you were when you heard the first gunshot. Your amygdala remembers, however. So the brain becomes hypersensitized to anything resembling the original trauma, sometimes without conscious awareness of the trigger. So you find yourself sweating and getting anxious and frightened, and you're not sure why this is happening at that particular time. So if this keeps on happening, you find yourself wanting to avoid these situations. So if this happens, you stop maybe going to Walmart. So then you go to Kroger next time, and then for some reason you find yourself reacting to somebody that may have looked a little bit like the shooter. So then you find yourself avoiding going to Kroger. So you can see how that goes. It becomes a vicious cycle with the amygdala always firing up. Those hormones are in your bloodstream, interfere with your frontal cortex, and it's just kind of a fear-mongering machine. So that leads to something like that. So in summary, re-experiencing is because of the amygdala being overactive. Because it's overactive, people will start avoiding situations and places. The hyperarousal is from the fight or flight response. Every time your amygdala fires up, hormones are being secreted into your bloodstream, and that interferes with the prefrontal cortex. So it's difficult to ever get a handle on things. So all of this makes it difficult to unlearn, because the only way you can unlearn something is by continuing to go to Walmart, for example. And even if you feel anxious when you enter the frozen food section, you still stay there and you force yourself to go there the next day. And eventually you will unlearn the fear by realizing that every time this is happening, nothing bad is happening. So I guess it's okay now. PTSD has been labeled a forgetting disorder because unlearning is what is impaired. Other people have called it a cueing disorder because cues, you can hear that as reminders or triggers, have become overgeneralized. Almost anything gets your amygdala going. But what's very important here is that PTSD stems from normal, natural responses to trauma that have gone awry. Keep in mind that our definition said that these symptoms have to be going on for at least a month. So what that recognizes is that these are normal reactions to trauma. What's abnormal is when they don't go away, when we don't unlearn the fear. And that's when it becomes a disorder. Now, once you have PTSD and you've had PTSD for a while, they have found out that the amygdala is usually enlarged and that the prefrontal cortex has thinned out. And this is a vicious cycle again, because you need your frontal cortex in order to tame the amygdala. So this is a vicious cycle. Now, some comments about COVID-19, because this is our current ongoing traumatic event. So what's unique about this is that, 9/11 was something that happened in the course of a day and a few hours. There was a beginning and an end. But with a pandemic like we have right now, there was a beginning, but there's still no end in sight. And prolonged exposure is what's the problem here. We know that that is more likely to lead to PTSD if something is prolonged. People are fatigued and leery because the threat is still ongoing. In addition, it's just not that we're afraid of something happening to us, but we're afraid of something happening to our family, our loved ones, our friends, and our coworkers. So there are going to be mental health consequences as a result of the pandemic, and it's not going to be limited to PTSD. People are anticipating higher rates of depression, anxiety, substance abuse, and suicide. Now, based on what we've talked about so far, you would now understand that you would be at greater risk of PTSD from the pandemic if you've been affected personally. So if you lost a loved one to COVID, if you yourself were infected, if you're a frontline worker or first responder, and we can't forget that if you've lost your job or have significant financial concerns as a result of all of that. So how can you protect yourself? How can you try to put the odds on your side that this won't lead to PTSD? Well, these are just general recommendations, make sense. Practice self-care. So make sure that you're sleeping, make sure that you're eating okay. Try to keep to a routine. For some people, that can be difficult because we're stuck inside our homes. We can't do the things that we used to do, like play pickleball or tennis, at least not inside. Try to turn to healthy distractions, taking walks, listening to music, and avoiding destructive ones such as turning to drugs or alcohol. From time to time, it might be wise to unplug from the news because it can be pretty depressing and it's hard to see the light at the end of the tunnel. Very important to stay connected. If you start to isolate, that's a warning sign because we talked at length earlier about how social support is important, and lack of social support is a risk factor for PTSD. And finally, if you recognize that you're getting in trouble and you're becoming more and more distressed or you're having trouble functioning, then it is definitely time to reach out to someone. So a brief note before we end on treatment options. Um, there are two main forms of treatment, obviously, therapy and medication. There are several different forms of therapy. Cognitive processing therapy, basically cognitive behavioral therapy. There's something called EMDR, eye movement desensitization, and I don't remember what the R stems from. That's one that's kind of weird. And then there's another one called prolonged exposure. So let's just talk briefly about each one of those. Now, CBT is felt to be the most effective treatment for PTSD. It's about trying to work your prefrontal cortex so that it becomes better at managing your feelings. Think of CBT that way. So you examine what the patient is thinking and telling himself about the trauma, and you decide whether these thoughts are accurate or inaccurate. Prolonged exposure means you expose yourself along with the therapist to certain thoughts, feelings, or even situations that you've been avoiding, and you learn to tolerate these feelings and thoughts better. It's a way of unlearning the fear. Again, the goal is to use the prefrontal cortex, the rational mind, to help you deal with the emotional mind. So EMDR is somewhat similar in that the therapist will ask you to recall distressing events, and then they will ask you to do something like move your eyes in a certain way or tap your fingers on the desk a certain number of times. And what apparently they're trying to do is by distracting you and making you focus on something else, it helps you tolerate the feelings and lessen how emotionally upsetting they become. That's the theory. Medication, we're primarily dealing with the antidepressants. Although we still call them antidepressants, they're probably prescribed as much for anxiety as they are for depression. The two antidepressants that are FDA approved for PTSD are sertraline, also known as Zoloft, and paroxetine, also known as Paxil. Studies show a modest response, which is true for all of our drugs and most of our disorders. 60% response means 60% of patients may experience a 50% reduction in symptoms, frequency and or severity. So that means people are still symptomatic, but less so. 40% remission means that maybe 40% of patients no longer have symptoms. And finally, benzodiazepines are drugs like Valium, Xanax, and Ativan. These are usually frowned upon as your main drug for dealing with PTSD. They work right away when you take them, and they are sedatives. The problem is that they kind of slow down the entire brain, and in the process, they target areas that are already hypoactive in PTSD, such as the prefrontal cortex. So a drug like Valium would not be a good idea to take on a regular basis for months on end or years on end for something like PTSD. However, I do think there is a role for these drugs to be taken on an as-needed basis. For example, you're trying to unlearn your fears by going back to Walmart. So taking a Xanax before going back to Walmart to help you tolerate the situation and make it so you can unlearn it seems a reasonable thing to do. And that brings us to the end of our presentation. I'll be happy to answer questions and hear any comments that you might have.
Thank you, Dr. Lacoste. Wow, that was heavy, and there's a lot there. We only have a couple of questions. I think everybody's thinking about what you were saying. It was wonderful. Thank you for that. So I do have one question that came up on sleeping. So do you have any recommendation for people who have PTSD and help getting to sleep? Is there anything you'd recommend?
Well, if what makes it difficult to sleep or to stay asleep is the fact that there are recurring nightmares, they use alpha blockers, something called Pressozin, for example, which is really a blood pressure medication that seems to have had some success in that regard. But if it's not because of recurring nightmares and it's just a question of falling asleep, then you have other drugs that are not addicting, like trazodone, which is an old antidepressant that's highly antihistaminic, and that's how it makes you drowsy. And an antidepressant called Remeron, mirtazapine, is another highly antihistaminic drug. So there are ways to be able to have something that's not addicting that could help you sleep.
Okay. I was curious, what is the recovery rate? I know there was a little bit of that on the medications that you listed, but what would you say the average recovery rate for people with PTSD?
Well, I'm going to have to say I'm stumped on that one.
I'm
I'm not sure. I would have to look it up.
Well, I'm just curious. It seems like when you have PTSD, it's hard to recover, and it's maybe you never 100% recover. I was just curious.
I wouldn't want to look at it in such a pessimistic way, but yeah, I'm sure there are people who never do recover and continue to be symptomatic. I'm sure that there are people that might be symptomatic for 6 months or a year, and maybe there is a way with treatment to alleviate that.
Right.
So again, it depends on the individual's vulnerabilities and the event itself also.
Right.
Dr. Lacoste. Oops, I'm sorry.
Oh no, I was just real quick. We did one of our Your Mind Matters presentations was on developing resilience, and I think that came to mind when I listened to you, because I think that can help prevent maybe our body responding that way in the event of a tragedy. That if we can develop some resilience, like you said, as we age, we tend to develop resilience, and we're less at risk for this. But that's something definitely that I think can help us, sounds like.
Right, resilience is the opposite of vulnerability, right? So, and yeah, if you can work out your prefrontal cortex, that's one way to try to develop resilience.
Right.
Sometimes shock, it's hard to prepare be resilient when it's something that's shocking, losing your job, different things like that. You try to, bump it up and be resilient. But sometimes I feel like when it's a shock to your system, it can be all encompassing, But doctor, I was going to ask you about EMDR therapy. Have you heard of that? And how do you feel about that for PTSD?
Well, I just mentioned something about that.
Okay.
Part of the treatment option. I've heard of it. I've never been exposed directly to it. It is mentioned every time you look up a treatment option for PTSD. It's a little, it's a little weird, but I think the idea is to somehow be distracted by doing something physical while at the same time experiencing the thoughts or the feelings.
Mm-hmm.
And it's a way of distracting your mind and force you to tolerate something. That's my understanding of it. And usually you only see that in connection with PTSD. You never see EMDR for any other psychiatric condition.
Right. So does anybody else have any questions?
Yes, I have one. Doctor, for a first responder, what may be the interval between you seeing something very tragic, like a young baby killed in an accident, to when this may crop up again in an exposure to another incident? Is there a time frame, the longer you go on without experience of a similar incident, that you're better off? Or
yeah, I would think so. Meaning, obviously, if you experience something upsetting, a rapid succession, then you're more vulnerable the second time because of the first time. But the more time elapses between the two, the less it's going to be a factor. Although what we talked about earlier in terms of prior trauma, it never completely goes away. But it also depends on the intensity of the trauma. With the figures that we discussed earlier about the first responder in 9/11, 5 or 6 or 8% develop, symptoms the first few months that they were exposed, but then 6 or 8 months later, nobody had symptoms anymore. So I wouldn't consider these people to have PTSD in the same way that the survivors from the towers have PTSD. You know, they were symptomatic briefly, and then they were able to recover. So the longer the time between the events, you know, the better, in terms of that gives you a little more of a buffer.
When I was in law enforcement, going back into, had quite a career in it, seems like your recovery from a tragic event, a bad automobile accident or something like that, is you went into the hospital and you drank coffee with the nurses, and you shared some stories, and you went back out on the road. There was you weren't identified of having any post-trauma. So what has changed since then?
Well, again, you know, they don't call it PTSD unless the symptoms have been present for at least a month. And a month is a very arbitrary number. You know, there's nothing that says, you know, the committee could have decided 6 weeks or 2 months or 3 months. So I think, you know, that we're more aware now of how trauma can affect us. But, you know, the problem is that if the symptoms go away on the 29th day, you don't have PTSD. But if it goes away on the 35th day, you have PTSD for a few days. You know, that's ridiculous to some degree to think of it that way. But, you know, so I think what is certainly normal is people develop stress-related symptoms, and that's normal. And if they become distressing and they don't go away, then you've got a problem that you need to try to address. But for most people, these symptoms will go away, whether they go away within a month or not. The majority of people will recover. And it's a minority of patients that will develop PTSD. I mean, think of 9/11, you look at 13% or 14% of the people who were in the towers. They were the most exposed, and it's still a minority of the survivors that have PTSD. So we're focusing a lot on vulnerabilities, but for the most part, people recover.
Doctor, we have another question, and this one kind of, you know, hits true to my heart. From Susan, she said, I just heard from someone today who lost a young child, and EMDR had helped them to recover. So that's the reason I mentioned it, was I lost my son 15 years ago, Monday. And I did the EMDR therapy.
Okay.
And it was very helpful for me. That was, you know, about 14 years ago, but it was really helpful. In what I really got from it mostly was the triggers, right? That I kind of, it helped me to kind of concentrate on different things rather than be triggered by dates and sounds and smells and things like that. But still, like Monday is the 15th year. So every time I say that, I have to take a deep breath, right? But I think to myself that, you know, 15 years is a long time. So, but it's like, sometimes it feels like it's come back. And I think that's how a lot of the Vietnam veterans that I talk to, they feel too, like they could go for 2-3 years. And police officers, you know, they come across a horrible accident and they go for 2 or 3 years, and then bam, they're like right back in there. And so it's like, sometimes it's something that you kind of always have to address, isn't it?
Correct. And the fact that, you know, you still have that reaction does not mean that you have a psychiatric disorder. I would simply view it that you're still having a reaction, but it's a normal reaction to an unnatural situation.
Right.
You know? So just having symptoms does not mean that you're mentally ill. We can't lose the fact that, you know, if you become unable to function as a result following the 15th anniversary and you're incapacitated for the following month, then there's a problem.
Right.
But if you have some, you know, you find yourself having a lot of different feelings, but you're able to still manage, then it's normal.
Yeah, I remember that day. You know, at first I couldn't do anything, but now, like, I can actually work on that day. I, you know, can just kind of treat it like another day in some respect. Makes me feel, and I just talked to my doctor about it, and I said, you know, sometimes I get sad, and he goes, if you didn't, that would be weird. So
Right.
we all have to kind of look at that way, right?
Correct.
Any other questions? And do we have any more? No?
I don't
Okay,
see anything on my end.
This was a really great topic, and I'm going to share this with a lot of Susan, it was a great presentation. We are recording this, so we will share it, and please, when I send you the link, share it with your friends, your neighbors, your family, because this is just really important information. And Dr. Lacoste, we cannot thank you enough. Stephanie, any last
one more
words?
question?
Oh,
sure.
yeah, there was one more question that came through.
I want to ask how we're doing with treating the Vietnam veterans. Are we picking up on those who weren't properly cared for?
Well, again, I don't think I have an answer for you. I mean, I can try to find one and try to convey that answer to you later. I think it's a very good question. I don't know how the Vietnam veterans have fared over the years, and whether this greater recognition of PTSD has led to, some positive outcomes for these folks. So I'm not aware of that. I can look it up.
I'm on a chat online with people with survivor guilt,
Mm-hmm.
and they just can't kick it.
Right. I mean, the Vietnam War was it was so different from the first two world wars in terms of how people felt coming home. So I suspect that there is more negative feelings associated with it than the First and Second World War. Second World War people came home as heroes. We were the good guys defeating the bad guys. Coming back from Vietnam, people wondered why you even went to Vietnam in the first place and thought this was a war that we should never have been in. And it was reflected on the veterans that came back, and it was bad. So it's a very emotionally loaded experience for these folks. They were not welcome home like in previous wars. So it came with a different feel attached to it, which I think made it harder. Yeah.
Mm-hmm.
Well, if you get a chance, Dr. Lacoste, to look up that data, feel free to send it to me, and I'll make sure it gets to Joan too, and that'd be wonderful. If you have some time to do that, it'd be great.
Okay.
I think that's it for this evening, though. We're almost at 8 o'clock, and thank you guys, all of you, for coming this evening. This is wonderful. Thank you, Dr. Lacoste. We really appreciate it.
Thank you, and I'm glad I had this opportunity. I know there was a lot of information. I was just trying to help everybody understand a little bit how PTSD develops and why these symptoms are there and what can be done about it.
Wonderful.
And I think this is definitely one of those that we're all going to want to rewatch, because you took in so much information, and then you kind of started thinking about it, and then you maybe missed a few things. So I think this is an important one to rewatch. So thank you again, everybody. Thank you, Stephanie. Thank you, Dr. Lacoste. And if anybody, the most important thing is to know that you're not alone, and we're all here for you. And so just reach out, or if you know a friend that's in pain or needs somebody, let us know, because we can reach out. Okay?
Absolutely.
All right.
Okay.
Have a good night, everybody.
Thank you, everybody.
Thank you.
Thank you.
All right. Good night.
Bye.
Bye, Dennis. Bye, Bob. Bye,
Bye.
darling.
Thank you.
Bye, Carrie. It's so good to see you.
Bye, Miss Marianne.
Bye, Pam. Tell your mom we love her.
Oh, yeah.
Bye, Abraham. Have a wonderful evening. Joan, you're a dream. Have a wonderful night. Let's talk soon, okay? Good night, everybody.